Welcome to HTL 302 Clinical Pathophysiology, and officially, welcome to Pathology. This course is where a lot of things you've already learned start to click together. You've probably studied anatomy, immunology, and definitely histotechniques. Now we're going to ask the big questions. What goes wrong? Why does it go wrong? And how does it show up in tissue? Pathology is the bridge between normal structure and disease. It's not just about identifying what looks abnormal, it's about understanding why those changes happened at the cellular and tissue level. As histotechnologists, you play a critical role in this process. The tissue you fix, process, section, and stain becomes the evidence used to make diagnoses. If pathology is the story of disease, you help preserve the chapters. Throughout this course, we'll focus on connecting mechanisms of disease to what we actually see under the microscope, because slides don't exist in isolation. They represent real people, real conditions, and clinical decisions. Don't worry though, we're not here to memorize every disease ever discovered. We're here to build a way of thinking about disease that will serve you in the lab, on exams, and in practice. So take a deep breath, get comfortable, and let's start building that foundation together. On this slide, you'll see the learning objectives for this lecture. I want to pause here, not to read them at you, but to frame how we'll actually use them. These objectives aren't busy work, and they're not just here to make accrediting bodies happy, although they do help with that. They're here to guide how you think about disease. We're going to start by defining what disease actually is, and more importantly, how modern medicine thinks about causation. That philosophical foundation matters because it influences how patients are diagnosed, treated, and studied. We'll also define pathology itself, not just as a subject, but as a discipline that connects structure, function, and clinical decision making. When we talk about manifestations of disease, we're talking about how illness presents in real people, not just what it looks like in a textbook. You'll notice we'll compare functional versus structural disease. This distinction is especially important for histotechnologists because sometimes disease is obvious on a slide and sometimes it isn't. Knowing that difference prevents overinterpretation and underinterpretation. We'll also identify exogenous and endogenous causes of disease. Remember to try and focus on the terminology. Pathology language is precise for a reason. Learning to use it correctly now will make everything else in this course and in your career much easier. Think of these objectives as a roadmap. By the end of this lecture, you should be able to explain disease clearly, thoughtfully, and accurately, from mechanism to manifestation. So before we go any further, we need to answer what sounds like a simple question, but obviously is not. What is disease? In pathology, disease is defined as a structural or functional change in the body that is harmful. That's important because it immediately tells us we're not just talking about symptoms, we're talking about underlying changes. At the cellular level, disease often begins when the cellular environment changes. When cells can no longer perform their normal functions efficiently, or at all, we start to see consequences that scale up to tissues and organs. Disease is also described as a condition resulting from anatomical distortion and physiological dysfunction. In other words, something looks wrong, works wrong, or very often, both. You'll notice an important distinction here. Disease does not include injury. Injury is typically an acute external event like trauma. Disease implies an ongoing pathologic process. That distinction matters clinically and histologically. The philosophical foundation of modern pathology is the cellular basis of disease. Every disease process, no matter how complex, can ultimately be traced back to deranged structures or functions at the level of organs, tissues, cells, proteins, or even genes. For histotechnologists, this concept is everything. The slide you're cutting, staining, and interpreting represents those cellular and molecular changes frozen in time. You're not just looking at pink and purple, you're looking at the physical evidence of disease. If you understand this framework now, the rest of the course will make much more sense, and your diagnostic confidence will grow with it. This slide reinforces what I would argue is the most important concept in pathology, the cellular basis of disease. On the left, you're looking at an actual histologic image. On the right, a schematic of a eukaryote cell. These are two representations of the same idea, one simplified, one real world. Disease does not magically appear at the organ level. It starts when cells stop behaving the way they're supposed to. That might mean altered metabolism, impaired protein synthesis, membrane damage, or failure of normal regulatory pathways. Every structure you see in the diagram, mitochondria, nucleus, ribosomes, endoplasmic reticulum, has a very specific job. When one of those jobs fails, the effects ripple outward from cells to tissues to organs and eventually to clinical disease. This is why pathology, and especially histotechnology, is so detail-oriented. You're preserving and visualizing cellular evidence of dysfunction. Subtle changes in nuclear size, chromatin pattern, cytoplasmic staining, or tissue architecture can be the first visible sign that something has gone wrong. One of the hardest but most important skills you'll develop is learning to think backwards. What cellular process must have failed to produce what I'm seeing on this slide? And just to ground this in reality, no, you won't see mitochondria waving at you under the microscope, but their dysfunction shows us indirectly through changes in energy balance, cell injury patterns, and tissue response. This slide is your reminder that pathology is not memorization, it's interpretation, and histotechnology is the bridge between cellular dysfunction and clinical diagnosis. When we say pathology, we're not just talking about looking at slides. Pathology is the study of disease, specifically the structural and functional changes that occur as disease develops. It answers three core questions. What went wrong? Why did it happen? And how does that explain what the patient is experiencing? The first bullet here is key. Basic structural and functional changes. Structural changes are what we see: altered tissue architecture, abnormal cells, disrupted organization. Functional changes are what those structures can no longer do effectively. The second bullet highlights the sequence of events. Disease is not a single moment, it's a process. Something abnormal occurs at the cellular or molecular level, that abnormality progresses, and eventually the patient develops clinical manifestations. That's such as symptoms, lab abnormalities, image findings, etc. As histotechnologists, you're often preserving tissue from the middle of that story. The challenge, and the skill actually, is learning to recognize where in the sequence the disease process is when the specimen arrives in the lab. The last term on this slide is etiology, which simply means the cause of disease. Pathology isn't complete unless we can connect what we see microscopically to why it happened in the first place. Genetic mutation, infection, immune dysfunction, ischemia, toxicity, or some combination of factors. And just to be clear, pathology is detective work, not fortune telling. We use patterns, evidence, and context, not vibes, to support diagnosis. The image on this slide captures that idea well. Pathology is about interpreting patterns across many specimens to understand disease at both the individual and population level. Let's keep on building what pathology actually looks like in the real world. Pathology is a medical specialty, but it's a little different from what most people picture when they hear doctor. Pathologists work primarily with body fluids and tissues for diagnostic purposes. That means blood, biopsies, surgical specimens, cytology samples, basically anything that can be collected, processed, and interpreted to answer the question, what's wrong? Pathology also plays a huge role in teaching and research. A lot of what we know about disease mechanisms, cancer progression, and treatment response comes from pathologic studies. In other words, pathology is the reason medicine moved beyond guessing and vibes. Now let's talk about subspecialties, because this is where histotechnology really shines. Anatomic pathology focuses on tissues and cells, so biopsies, resections, frozen sections, cytology. This is your home base. If it goes through fixation, processing, embedding, sectioning, and staining, it probably falls under anatomic pathology. Clinical pathology deals with laboratory analysis of body fluids, so hematology, chemistry, microbiology, transfusion services. You may not work directly in these areas, but your work absolutely intersects with them. Research pathology bridges the two and pushes the field forward. It's where new stains, biomarkers, and diagnostic criteria are developed, often before they ever show up in clinical practice. A fun fact slash worthless knowledge moment here. The average pathologist makes thousands of diagnostic decisions a day, but almost no one outside of healthcare knows what they actually do, which means you are entering a profession that is both highly specialized and criminally misunderstood. And one last thing to ground this. Those images on the slide represent very different tissues, but they're all telling stories at the cellular level. Your role as histotechnologists is to make sure those stories are clear, accurate, and interpretable. No pressure, but also, yes, pressure. Just the good kind. Now we're going to zoom in out a bit and look at pathology specialties because pathology is not one size fits all. It's more like a really nerdy buffet. Let's start on the left with anatomic pathology, which is where most of you will spend your professional lives. Anatomic pathology supports clinical practice, teaching, and research, and it focuses on tissues and cells. Surgical pathology is exactly what it sounds like. Tissues removed during surgery that need to be processed, sectioned, stained, and interpreted. This is where turnaround time matters, orientation matters, and one tiny curl in a ribbon can suddenly become very important. Cytopathology focuses on individual cells, like pap tests, fine needle aspirations, body fluids. Fewer cells, higher stakes, and absolutely no room for sloppy preparation. On the right side, we have clinical pathology, which deals primarily with laboratory testing and analysis of body fluids rather than tissue architecture. This includes chemistry, hematology, microbiology, blood bank and transfusion medicine, immunopathology, and molecular diagnostics. Sorry. Even if you don't work directly in those labs, your work overlaps with them constantly, especially as pathology becomes more integrated and data-driven. A fun fact that sounds fake but is not, modern molecular diagnostics can identify certain cancers and infections faster than cultures ever could, sometimes before symptoms fully develop. The microscope still matters, but it now has very tech-savvy friends. And here's the big takeaway. No matter which specialty we're talking about, pathology depends on accuracy, preparation, and interpretation. Histotechnologists are a critical link in that chain. If the tissue isn't well prepared, the fanciest test in the world won't save the diagnosis. Now we're going to talk about manifestations of disease, which is just a fancy way of saying how disease shows itself. One of the most important skills in healthcare, and pathology specifically, is understanding what kind of information you're looking at and who it comes from. This table helps organize that. Let's start with symptoms. Symptoms are based on the patient's perceptions. These are things the patient feels and reports: pain, fatigue, nausea, dizziness. If the patient says it's a symptom. Symptoms are collected as part of the patient history, and yes, they matter, even if they're subjective, because ignoring how a patient feels is a great way to miss something important. Next are signs. Signs are the examiner's observations, things that can be seen, measured, or detected during a physical exam. Think swelling, rashes, abnormal heart sounds, or even a fever. If you can point to it, measure it, or document it without asking the patient how they feel about it, it's probably a sign. These come from the physical examination. Then we have laboratory abnormalities, which is where pathology really starts to flex. These are results of tests and special procedures, blood counts, enzyme levels, cultures, immunoassays, molecular results. These are collected as laboratory findings, and while they look objective and clean on paper, they still depend on proper specimen collection, handling, and processing, which is where histotechnologists quietly save the day. Finally, we have radiographic abnormalities, findings from imaging studies like X-rays, CT scans, MRIs, and ultrasounds. These are grouped as radiographic findings. Fun but true fact, sometimes radiology, labs, and histology all tell slightly different versions of the same disease story. Your job is not to compete, it's to contribute accurate data so the full picture makes sense. The big takeaway here is this: no single manifestation tells the whole story. Disease is understood by putting symptoms, signs, laboratory data, imaging, and tissue findings together. And yes, pathology often gets the final word, but only if the work leading up to it is done well. Let's continue with manifestations of disease by looking at two terms that are often confused or causally interchanged: diagnosis and syndrome. Starting on the left, diagnosis. A diagnosis is not one single test result or one isolated finding. It's the assimilation of information from multiple sources. This includes the patient history, the physical examination, and laboratory findings, and yes, that includes histologic findings when tissue is involved. Diagnosis is essentially the process of putting all the pieces together and deciding what disease process best explains what we're seeing. Think of diagnosis as the final answer to the question, what is going on with this patient? Now let's contrast that with a syndrome, which lives on the right side of the table. A syndrome is a cluster of findings that tend to occur together. Importantly, a syndrome is not specific to one disease. The same syndrome can be seen in multiple different disease processes, which is why syndromes are often descriptive rather than definitive. A syndrome is basically medicine saying, we recognize this pattern, but we're not done investigating yet. Syndromes are described using groups of symptoms, signs, and laboratory findings, but they stop short of naming a single cause. That's why you'll often hear phrases like consistent with or suggestive of when syndromes are discussed. A fun clinical reality check. In pathology, we sometimes get specimens labeled with a syndrome rather than a diagnosis. That means our job is to help narrow the possibilities by providing clear, accurate morphologic and diagnostic data. The key distinction to remember is this: diagnosis names the disease, syndrome names the pattern. Both are useful, neither works alone, and pathology plays a major role in moving from one to the other. Now we're going to talk about structural diseases, which you'll also hear referred to as organic diseases or organic disorders. These terms all mean essentially the same thing: diseases that produce symptoms because there is a detectable physical change in the body. And when I say detectable, I mean detectable by imaging, laboratory testing, gross examination, or microscopy, which is where we come in. Structural diseases cause symptoms because something has actually changed in the structure of cells, tissues, or organs. Not imagined, not functional only, but physically altered in a way we can observe or measure. From a histotechnology perspective, these are the diseases that most often land on our benches. If there's a biopsy, a resection, or a special stain involved, you're almost certainly dealing with a structural disease. On the right side of the slide, you'll see the major categories of structural disease. First, genetic and developmental diseases. These arise from inherited mutations or errors developed during development and often show characteristic histological patterns. Sorry about that. Next, we have degenerative and inflammatory diseases and trauma. This is where you'll see tissue breakdown, inflammatory infiltrates, necrosis, fibrosis, basically all the something went very wrong here features under the microscope. And finally, hyperplasia and neoplasms. This category is especially important because it includes both benign and malignant growth processes. These are conditions where cell number, organization, and behavior change in ways that are often unmistakable histologically. A fun but useful fact: the term organic disease doesn't mean natural or healthy. It simply means there's a structural basis you can point to, not a philosophical stance on diet or lifestyle. The big takeaway here is structural diseases leave footprints, and histotechnology is one of the ways medicine finds and interprets those footprints. Now let's contrast structural diseases with functional diseases. Functional diseases are defined by symptoms without an identifiable anatomical or physiological cause at the time of onset. That last part matters: at the time of onset. In other words, the patient is experiencing real symptoms, but when we look with imaging, labs, or even histology early on, we don't yet see a clear structural abnormality to explain them. This does not mean the symptoms aren't real. It means the dysfunction is occurring at a level that isn't immediately detectable with our current tools, or hasn't yet produced visible tissue changes. Some commonly cited functional disorders include tension headaches and irritable bowel syndrome, where patients experience significant symptoms even though early diagnostic testing may appear normal. You also see conditions like hypertension and diabetes listed here. These are great examples of why pathology isn't always black and white. Early in this course, these diseases may behave like functional disorders, symptoms and abnormal physiology without obvious structural changes. Over time, however, many of these conditions do progress into structural disease, producing histologic changes in vessels, kidneys, pancreas, and other organs. So think of functional disease as a snapshot in time, not a permanent category. From a histotechnology standpoint, functional diseases are important because they remind us that absence of visible pathology does not equal absence of disease. Sometimes the tissue just hasn't left footprints yet. Fun but useful fact, many conditions once considered purely functional, like peptic ulcer disease, were later found to have clear structural and infectious causes once better tools became available. Science evolves and pathology evolves with it. The takeaway here is balance. Structural diseases show us where the damage is. Functional diseases remind us that disease often begins before the damage is visible. Now we've talked about what disease looks like, let's talk about where it comes from. Broadly speaking, the causes of disease fall into two big buckets, exogenous and endogenous. Exogenous means external, something that comes from outside the body. Think of these as the things your body didn't invite but got anyway. Endogenous means internal, causes that originate within the body itself, often related to genetics, metabolism, immune responses, or internal regulatory failures. Both types ultimately cause cell injury, and that injury, whether subtle or severe, is what drives disease development. A helpful way to think about this is exogenous causes are things that happen to you, endogenous causes are things that happen within you. And sometimes, because biology loves chaos, you get a little of both working together. From a pathology and histotechnology perspective, we don't just care what the injury looks like, we care what started it, because that context helps guide diagnosis, prognosis, and treatment. Fun but useful fact, because I love giving those. Two patients can have nearly identical tissue changes, but completely different causes. Pathology is part science, part detective work, and part why is this body doing this? Over the next few slides, we'll break exogenous and endogenous causes down further, so you'll start seeing how specific insults translate into specific cellular and tissue responses. These are exogenous causes of disease, meaning the injury comes from outside the body. Think of exogenous causes as the body saying, I was doing fine until something showed up uninvited. We group these external insults into three broad categories: physical, chemical, and microbiologic injury. Physical injuries are usually the easiest to understand because they're very concrete, sometimes literal. Trauma can include things like blunt force, sharp injuries, or repetitive stress. Temperature extremes remind us that cells have a very narrow comfort zone. Too hot or too cold, and proteins start behaving badly. Electricity and atmospheric pressure injuries may sound rare, but they're important in occupational medicine, diving injuries, and aviation medicine. And ionizing radiation, while incredibly useful diagnostically and therapeutically, can damage DNA if exposure isn't controlled. Fun fact here, cells don't feel trauma the way we do. They respond to membrane disruption, protein denaturation, and DNA damage, which is a very cell-like way of panicking. Chemical injuries involve substances that interfere with normal cellular function. Poisoning is often dose dependent. The dose makes the poison. Even water can be toxic in extreme amounts, which is a fun fact students don't believe until they Google it. Drug reactions are especially important clinically because a medication meant to help one system might unintentionally harm another. And environmental toxins like heavy metals or industrial chemicals often cause chronic, low-grade injury that accumulates over time, which makes them harder to detect early. Microbiologic injuries come from living or once living organisms that really want your nutrients. Bacteria and viruses get the most attention, but fungi, protozoa, and helminths and rickettsia, are equally impressive in their ability to disrupt normal physiology. What makes microbes fascinating from a pathology perspective is that injury often comes from both the organism and the body's immune response to it. Worthless but memorable facts: helmets are large enough to see without a microscope, yet they still somehow manage to evade the immune system for years. So truly, truly rude behavior. The key takeaway here is that exogenous causes initiate injury, but the disease we see depends on how cells and tissues respond to that injury. Same exposure, different patient, different outcome, because biology is personal and cells are dramatic. Now we switch gears to endogenous causes of disease, meaning the problem starts inside the body. If exogenous disease is something attacked me, endogenous disease is more like my own systems aren't cooperating today. These causes arise from normal internal processes that go wrong, become unbalanced, or overreact. Vascular causes involve problems with blood flow, either too little, too much, or going where it absolutely should not. Obstruction might mean a clot or narrowing that blocks blood supply. Bleeding speaks for itself. Blood is very useful inside vessels, much less so when it escapes. Deranged flow includes things like shock or ischemia, where tissues aren't getting what they need to survive. Fun but unsettling fact: cells can tolerate lack of oxygen for only minutes, but the brain is especially dramatic about it. Immunologic causes are all about regulation or lack thereof. Immune deficiency means the body can't respond adequately to threats. Allergies happen when the immune system responds too enthusiastically to something harmless. And autoimmunity is when the immune system loses the instruction manual and starts attacking self tissues. Your immune system performs millions of recognition checks per day and occasionally still gets it wrong. Accuracy is impressive, but not perfect. Metabolic causes involve abnormalities or deficiencies in substances the body depends on to function. So lipids, carbohydrates, proteins, minerals, and vitamins all have narrow, just right ranges. Too little or too much can disrupt cellular function. These disorders often develop slowly and can affect multiple systems at once, which is why metabolic diseases are sometimes tricky to diagnose early. Many vitamin deficiencies don't show symptoms immediately because the body stores reserves until one day it suddenly doesn't. Endogenous causes remind us that disease doesn't always need an outside trigger. Sometimes disease happens because normal systems, vascular, immune, or metabolic, lose balance. Pathology is largely the study of how those imbalances show up at the tissue and cellular level. This brings us to one of pathology's favorites and most humbling terms: idiopathic. Idiopathic simply means the cause is unknown. Not we didn't look, not we don't care, but despite extensive research, testing, and data, the exact cause has not been clearly identified. Idiopathic does not mean imaginary. It does not mean rare, minor, or untreatable. It means the disease clearly exists, produces measurable changes, and has real consequences. We just don't fully understand the initiating cause yet. Fun pathology reality check: many diseases that were once idiopathic no longer are. Science does catch up, slowly, but persistently. Several of the conditions listed here, like type 1 diabetes, Hashimoto's thyroiditis, Graves' disease, Sjogren's syndrome, and rheumatoid arthritis, are strongly associated with autoimmune mechanisms. We understand what the immune system is doing, but not always why it started doing it in the first place. Celiac disease is another great example. Genetic predisposition plus environmental triggers are involved, but the full sequence of events is still being unraveled. The word idiopathic comes from Greek roots meaning one's own suffering. In practical terms, clinicians sometimes jokingly translate idiopathic as "we don't know yet." And honestly, that "yet" matters a lot in medicine. Even when a disease is idiopathic, diagnosis and treatment still rely on recognizable patterns, laboratory findings, histologic changes, clinical response to therapy. Pathology often helps define what the disease looks like, even when the trigger remains unclear. Idiopathic disease reminds us that medicine is both advanced and incomplete. Pathology doesn't require absolute answers. It requires careful observation, pattern recognition, and evidence-based reasoning. Now we're moving into another term you'll hear throughout your career, iatrogenic disease. Let's start with pronunciation because this one trips everyone up. Iatrogenic. If you say it confidently, no one questions you. That's a general medical survival tip. Iatrogenic refers to a condition that results from medical treatment or intervention. This includes medications, procedures, diagnostic tests, anything done with the intention of helping the patient. Key point, iatrogenic does not mean malpractice. It means an unattended adverse effect, even when care is appropriate and evidence-based. A classic example is aspirin causing peptic ulcers. Aspirin is widely used, effective, and generally safe, but it can disrupt prostaglandin production and compromise gastric mucosal protection. Another example involves sulfonamides and tetracyclines, which can cause photosensitivity reactions. Medication itself isn't harmful, but when combined with UV radiation, patients may develop significant skin reactions. This is why patient education matters just as much as prescribing the drug. From a pathology standpoint, iatrogenic disease often shows up as tissue injury, inflammatory changes, drug-induced patterns we learn to recognize. Sometimes the hardest diagnostic question isn't what disease is this, but could this be treatment related? The root iatro comes from Greek and means physician. So yes, iatrogenic literally translates to originating from medical care. That sounds scary, but it's actually a reminder that medicine is powerful, and powerful things have side effects. Iatrogenic disease highlights the balance between risk and benefit. Nearly every effective treatment has potential adverse effects. The goal is not zero risk. It's informed decision-making, monitoring, and prevention when possible. That image on the slide, it's basically why medication inserts are longer than your syllabus. And yes, you are absolutely allowed to laugh as long as you also read them. Idiopathic disease reminds us we don't know everything. Iatrogenic disease reminds us that what we do matters even when we do it correctly. This slide introduces nosocomial infections. Nosocomial infections. I cannot say that word at all. And yes, that's another one of those words that sounds scarier than it needs to be. Nosocomial simply means acquired in a hospital or healthcare setting. Translation, the patient did not walk in with it. These infections develop during or after hospitalization, often related to procedures, devices, or prolonged exposure to healthcare environments. Common examples include urinary tract infections, often associated with catheters, surgical site infections, gastroenteritis, meningitis, pneumonia, especially ventilator-assisted pneumonia. You'll notice a theme here. Devices plus procedures plus vulnerable patients equals opportunity for microbes. Hospitals are full of sick people, invasive procedures, antibiotics, and microorganisms that have learned to adapt and survive. From a microbial perspective, hospitals are basically elite training camps. The cartoon on the slide highlights MRSA, one of the most well-known nosocomial pathogens. MRSA isn't stronger because it's evil, it's stronger because we selected for resistance over time. And yes, the sign about washing hands, that's not a suggestion. That's infection control doing its best work. The word nosocomial comes from the Greek nosokomion, meaning hospital. So if you ever blank on the definition, just remember noso equals hospital. Your future self will thank you on an exam, I promise. In pathology and laboratory medicine, nosocomial infections matter because they affect patient outcomes, they influence antimicrobial stewardship, they complicate diagnoses, and they often show distinct patterns in cultures and tissues. Sometimes the most important diagnostic question is, did this infection start before or after admission? It's also important to remember that nosocomial infections are system-level issues, not patient failures. Risk is higher in patients who are immunocompromised, older adults, neonates, or those requiring long hospital stays. Prevention depends on systems, training, and resources, not blame. Nosocomial infections remind us that healthcare environments must constantly balance care delivery with infection prevention. Clean hands, clean instruments, but good protocols save lives, and sometimes more than the most advanced treatments. All right, so let's land this plane. This slide is your big picture moment. If everything we just talked about felt like a lot, that's normal. This is where it all clicks together. First big takeaway, disease results from structural and/or functional changes. Something changes, either you can see it, structural, or you can't see it yet, functional. But either way, normal physiology is disrupted. When things stop working the way they should, symptoms follow. Second, and this one shows up everywhere in pathology, all disease has a cellular basis. Even if imaging looks normal, even if labs are mostly fine, even if the patient just says, I don't feel right, if it's real disease, cells are involved. Always. Cells don't lie. They just sometimes whisper before they scream. And now let's talk about what pathology actually does, because this is a test favorite. Pathology helps us answer three core questions. What caused the disease? That's etiology, the why. How did the disease develop over time? That's pathogenesis, the how and the sequence. And how does the disease show up clinically? Those are the manifestations. So symptoms, signs, labs, imaging. If you can walk through those three steps logically, you're doing pathology correctly. So if you're ever stuck on an exam question, pause and ask yourself, is this a cause question, a development question, or a presentation question? That mental reset alone will save you points. This slide is basically your mental checklist. If you can walk through this slide calmly, you're in very good shape. Let's start with manifestations of disease, because this is how disease shows up in the real world. Manifestations include symptoms, what the patient tells us, pain, nausea, fatigue, something feels off. If the patient says it, it's a symptom. Signs, what the clinician observes. So fever, rash, swelling, abnormal reflexes. If we see it, measure it, or hear it, it's a sign. Laboratory and radiographic findings, what the data tells us. Labs don't have opinions. Imaging doesn't guess. These are objective findings. Next, we classify types of disease. Diseases may be structural, organic. This is a detectable physical change. You can see it on imaging, histology, or gross exam. Functional, symptoms are real, but structural changes aren't identifiable at onset. Important reminder, functional does not mean made up. Then we get to the causes of disease, which is where a lot of exam questions live. So causes may be exogenous, external causes like trauma, toxins, infections, or radiation. Endogenous, internal causes like genetic, metabolic, vascular, or immune problems. Or they may fall into special categories. Idiopathic, we don't know the cause, and that's okay. Iatrogenic, caused by medical treatment. Nosocomial, acquired in a healthcare setting. If you notice, everything on this slide ties back to the same idea. What changed, why it changed, and how we know it changed. And that's pathology in a nutshell. So this is our last slide for lecture 1, and it's the one I care about the most. If you remember nothing else from this chapter, remember this. Disease starts in cells. Every disease, no matter how it shows up, begins with a cellular change. Disease presents as manifestations. That's what we recognize clinically. Symptoms the patient reports, signs the clinician observes, and laboratory or imaging findings that confirm what's happening. Disease is classified by cause, external or internal, known or unknown, treatment-related or hospital-acquired. Classification helps us understand why disease occurred and guides care. Now zoom out to the big picture. Pathology is the bridge between cellular change and clinical care, and the laboratory plays a central role in making disease visible, turning what's happening at the cellular level into information clinicians can act on. So think in flow. Cells go to change, changes manifestations, manifestations into classification. If you can follow that pathway, you'll do well. And more importantly, you'll be thinking the way healthcare professionals should think.